Okay. Systematic desensitization is basically a psychological evidence-based intervention, which means that it tries to focus on the participants' thoughts and feelings around the phobic stimulus, around the thing that they're scared of. So it involves progressively, so progressively means little by little, step by step, exposing the patient to similar stimuli as the phobic stimulus. So if the person is scared of teddy bears, for example, you might first show them a picture of a teddy bear. Then you might, make them watch, like, I don't know, what's a TV show with a bear in it, like Paddington, or some TV show that's got a teddy bear in it. Then you might get them to maybe read a book about a teddy bear. Okay, so like the tasks start off pretty straightforward and pretty less intimidating or less threatening, and they start to begin more threatening the higher up you go in the hierarchy. Okay, so obviously the second step of systematic desensitization is to create the fear hierarchy, with the first step being to teach the relaxation technique. Okay, why do we teach the relaxation technique first? Well, it doesn't really, the order doesn't really matter, but it makes sense for you to teach the relaxation technique first, because then when the patient is actually going through the fear hierarchy step by step and task by task, they can practically use the relaxation technique to calm themselves down. So, for example, if I teach the person breathing retraining, how to breathe in a calm way to induce a sense of relaxation, if I teach them first, then I make them do the tasks in the fear hierarchy. Okay, if they're onto the first task and they have to look at a picture of a teddy bear, and they start to hyperventilate and they start to get really agitated just by that task, they can then use the breathing retraining relaxation technique that I taught them at the beginning to calm themselves down. So it's kind of a way for the participant to both calm themselves down and to start to associate each task with a relaxation response rather than a fear response. So that's kind of the reasoning behind why we teach them the relaxation technique first. Okay, the main aim is to disassociate. So we want to undo the association. We want to reverse that associative learning that has taken place. So we want to disassociate the phobic stimulus from the fear response, and we want to associate the phobic stimulus with a response of relaxation rather than fear. Okay, so that's why we encourage the patient each step of the way in each task of the fear hierarchy to use the relaxation technique. So this is what a fear hierarchy looks like. Now, you're not going to be ever asked to create a fear hierarchy in this much depth or this much in this much depth or in this much detail. But what you will be asked to do is, if we ask you, for example, to explain how systematic desensitization could be used to help a patient, then obviously you are going to at least give me at least 2 or 3 examples of tasks that might be included in the fear hierarchy. So maybe one example of a really easy task, one example of a really medium level task, one example of a very scary or fear inducing task. Okay, so to give you an example that's not related to dogs, if I'm scared of birds, okay, this is always the example I use for some reason. If I'm scared of birds, the first task on the fear hierarchy, so if I'm working with my psychologist to create a fear hierarchy, the first task we might do would be obviously not very scary, not very fear inducing. So something like, looking at a picture of a bird in a storybook. Okay, just looking at a picture of a bird, it's just a picture, it's not scary, it's not fear inducing. That's the first task. Another task in the fear hierarchy could be maybe watching a documentary about birds. Okay, that's a little bit more scary because the birds are actually moving on the screen, but still not super, super scary. The third, another task which might be higher in the fear level could be something like, walking in a park or walking in a beach where there tend to be a lot of birds. So that's a lot more scary because the birds are actually around you now. It's real birds we're talking about, and the actual chance of being attacked or the chance of being completely exposed to those birds is quite high. So those are just 3 examples of things that the patient with a phobia of birds could do that we could put onto a fear hierarchy. So again, if you ever asked a question on systematic desensitization on the SAC or on the exam, this is what you are expected to talk about in reference to the fear hierarchy. You should give specific examples of tasks that would be relevant to that patient's hierarchy in that scenario that you're given. Okay, so it's really not that hard. Just think of a low, medium, and high level task, which would go from not inducing much fear to inducing a lot of fear. Okay, and don't forget to talk about the relaxation technique, which we introduced to the patient right at the beginning. Okay, and obviously the end goal of systematic desensitization, as is the end goal with any treatment in specific phobia, is to undo that association between the phobic stimulus and fear. Okay, we know that obviously when phobias are classically conditioned, the conditioned stimulus is the phobic stimulus. So dogs would be the phobic stimulus, and dogs cause a conditioned response or a conditioned fear phobia response of fear due to the dog. So that's the fear response. So rather than the patient having fear due to the dog, we want them to have relaxation due to the dog, a feeling of calm due to the dog, or any response other than fear. Okay, that's what the end goal is basically. That has basically got to be. Okay, so that's basically systematic desensitization. So 3 steps. Number 1, teach the patient a relaxation technique. Could be any relaxation technique as long as it helps them to relax. Okay, the most common ones are like breathing deeply or breathing calmly, muscle relaxation techniques, meditating, like just blocking out the stimuli, all that kind of stuff. The second step is to create a fear hierarchy. So obviously with at least 2 or 3 examples of tasks that could be on the fear hierarchy. And the third step is to expose the patient to the actual dog or to the actual bird or to the actual phobic stimulus and see whether they show a fear response. So let's say I'm in the last stage of my fear hierarchy. I'm doing the task where I'm walking with the psychologist, we're walking on the beach, and there's birds all around me. When I see those birds, if I still show a fear response and I'm still hyperventilating and I'm dying and I'm about to like have a heart attack, that's a sign that systematic desensitization hasn't worked. Or that's a sign that I'm not yet ready for this task and I have to go back a few tasks. I have to go down a few tasks and work my way up again. Okay, because it's a sign that systematic desensitization hasn't yet been successful in managing my specific phobia or undoing that association between the phobic stimulus and the conditioned response. So hopefully that makes sense. Any questions, any clarifications further required for that? And yeah, the limitations. Yep.
So what if a person, right, she or she going through systematic desensitization, right?
Yep.
But they get so scared that they leave the whole program. What do you write? Or like, what do you write if they leave it completely?
You mean if it's mentioned in the scenario that they leave the whole program?
Yeah, if they leave the whole program because they got so scared.
Usually, if they were to leave the whole program, they wouldn't really ask you to talk about how systematic desensitization is used. But then if they say something like explain how systematic desensitization may be used to treat Claire's phobia, then you'd still have to explain it. So it depends on how they word the question.
Okay.
So again, what you mentioned is exactly right in terms of limitations of systematic desensitization. A lot of the time, people, even if it's little by little or step by step, people don't want to be exposed to their specific phobic stimulus or even to something that resembles the phobic stimulus. So that's one of the main limitations of systematic desensitization, along with the fact that people are not patient. They want to see results straight away. Systematic desensitization does require you to put in some time and some effort. So obviously it can be confusing, and it can be it can be confusing for the patient when they realize that it does take a lot of time. I thought this was an instant fix. Okay, a lot of patients have expectations and sometimes the treatments don't meet those expectations. Okay, so those are just some limitations. Again, just know one limitation. That should be more than enough. Alrighty, so I think that's systematic desensitization covered. So we'll go to the next topic, which was what was it? Types of social support. So let me just open up that PowerPoint. And I don't see any other topics in the chat box. So if you guys have topics, you need to let me know. This is the last opportunity before the SAC. Okay, anyway, we go on to social support. So yeah. Okay, open that up and new share and share screen. Where is it? Let me just do that again. Okay. Yep, this one, and then share, and then full screen. All right, so we've got social protective factors. So obviously we're talking about support from family, friends, and the community. So When we're talking about social protective factors, we're talking about essentially social support. Okay, in chapter 14, we learn about 3 types of protective factors. Now, protective factors are just what the name suggests. We're talking about factors that protect a person in terms of their mental health. So they either protect them from developing a mental disorder, or if they're already experiencing a mental disorder, they help to ease and relieve them of their symptoms. Okay, so protective factors are always a good thing, regardless of whether you have or don't have a mental disorder. So when we're talking about social protective factors, we're specifically talking about social support. And we know that social support can come from our family, from our friends, or the community. And specifically, we're talking about the fact that social support is directly helpful for mental health and well-being, because if you remember in chapter 11, one of the characteristics of a mentally healthy person is social well-being. Okay, and social support helps to build social well-being. Okay, if we know that there are people that we can lean on, that we can seek support or help from in a time of need, that helps us feel like we are supported, that we have someone that's got our back. Okay, so essentially social support increases a person's social well-being, which helps them to be a more mentally healthy person. Okay, so that's the kind of link between those 2 topics there. Now, looking at the types of social support, we know that social support can come in different forms. So there are 4 main types of social support that we look at, okay? And we use the memory tip ATI to remember them. So A stands for appraisal support. Appraisal support is, you would remember the word appraisal from the transactional model of stress and coping that we did in chapter 3. Appraisal is a judgment or an interpretation. So remember, when we first encounter a stressor, we make a primary appraisal, which is a primary or initial interpretation or judgment of that stressor. So sometimes when we go through a stressful situation, you know, we don't really, sometimes we get really stressed about it, or over worried, or overly agitated, because we don't fully understand the nature of the stressor. We don't understand the implications, okay? So sometimes we need access to somebody who can help us to better judge that stressor, who can help us to better make a proper evaluation or judgment of that stressor. Okay, and further on, you can obviously talk to them about your feelings, thoughts, worries, or concerns regarding the stressor. So just to give you a clear example, if I, for example, you know, if I'm the first person in my family to do VCE or something like that, and I don't have any older siblings or older siblings that have done VCE before me, when it comes to things like VTAC and stuff, I might be super stressed. I might be like, oh my God, I missed this deadline, blah, blah, blah. Like, I might get really stressed. But then if I've got someone like an older brother or older sister who's done VCE before me, or even like an older friend who's done VCE like a year or 2 before me, they might be like, hey, why are you stressing? Don't you know that VTAC have like a late submission? So it's not like it's all over. You just have to pay a late fee, and you can obviously just submit your application. Like, it's not a big deal. So by them saying that to me, they're helping me to rejudge or reevaluate the stressor. So from me, I go from thinking, oh my God, it's the end of the world, I didn't submit my VTAC application on time, I won't go to uni, blah, 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 to actually thinking that, hey, you know what, it's not a big deal. And, you know, I can just submit a late application like my friend told me. So my friend has essentially now helped me to better appraise the stressor, or to make a better judgment of the stressor. And so she's provided me social support in that way. Tangible assistance is actual stuff. Like, that's the most simplest way of explaining it. Tangible assistance is when you provide someone help, either through giving them actual stuff or materialistic things like money, or you let them borrow some kind of a resource or object that you have, or you help them with routine chores or jobs. So it's either your personal effort or energy that's going into helping them, or it's an actual materialistic item such as money that you're helping them with. So tangible assistance, tangible is something that we can measure. Okay, and tangible, another word for tangible is actual. Okay, tangible means actual. So it's an actual thing that you can measure, or you can kind of quantify or see, essentially. Okay, so basically that is what tangible assistance is. Information support. So information support is obviously important a lot of the time, because sometimes we don't always have information that can help us to better judge a stressor. So information support is important because sometimes we have mental health issues, but then we don't know how to deal with them, or we don't have enough information about how to manage those conditions. So information support is going to websites like Beyond Blue or Headspace, or even just talking to someone who's got some information that you don't have. So if you remember when we talked, when we're talking about information support, it doesn't only have to be information about mental health. It could even be information that comes from like a counselor. It could be information that comes from a careers practitioner, okay? If you don't have enough information about university pathways, you often go to your careers counselor because they've got that information that can help you, that can ease your stress. So that's basically information support. When you feel supported by people who have information that you don't have access to yourself. And emotional support is basically support where it's not really about getting information from a person, but it's more about helping a person to feel better emotionally, okay? To understand that someone does care about what they're saying. And it's not even always about, if I'm going to get emotional support from someone, that person doesn't have to become a psychologist. All they have to do is maybe listen, or give me their attention and just listen to my problems. They don't need to try to solve my problems. That's what emotional support is. Emotional support is just having someone that you can spend time with who will listen to what you're trying to say. And it doesn't necessarily have to be providing them with advice or even providing them with guidance or anything like that. Just simply listening helps to elevate people's emotional state, make them feel more safe and more happy and that kind of stuff. So yeah, those are the 4 main types of social support. And all of these types of social support act as protective factors because they help a person to maintain their mental health, as we learn in chapter 14, or even if you've got depression or some other mental disorder, they help you to ease your symptoms as well. Okay, so that's basically the 4 types of social support. So hopefully that's clear. Let me go back to the chat box now and see what else, what other topics. Can we do Kahoot like a quiz? We did Kahoot on the holiday class. I have no Kahoots prepared for today. What you can do though is you can go to Education Perfect. So go to Edroller, and on Edroller they have topic exams that you can do online. So those do have multiple choice in them as well. So you can attempt those. Those are really good, and most of you I think still haven't attempted them. So just give those a go. And yeah, if you haven't already done the practice SAC, you can do the practice SAC as well. Are we supposed to know the whole biopsychosocial model to specific phobia? Listen, the way that we learn the topics, we do apply the biopsychosocial model to specific phobia. So when we learn about like the biological contributing factors for specific phobia, like GABA dysfunction and all that stuff, or when we learn about the psychological contributing factors to specific phobia, or the social contributing factors, all of those are basically applying the biopsychosocial model. So I'm not going to give you a question, or you're not ever going to get a question, hopefully, that asks you to talk about specific phobia in terms of the entire biopsychosocial model, because that will be a huge question for a SAC. For a 10-mark question in the exam, it could be something that could work, but for a SAC, no. You're not going to be asked to apply the whole biopsychosocial model. We would ask you for specific parts of that though. So we might ask you to discuss the psychological contributing factors to specific phobia, okay? Just like one part of it, not the whole thing as a single question. Okay, so what other questions? I don't see any other topics that you guys want me to go through in the chat box. So either you guys know everything, or hopefully you don't know what you don't know. I don't know what's happening. So you got to tell me. Come on.
Miss?
Yes?
In Odrolo,
yes?
area of study 3 for unit 4, which it has research methods and stuff. And obviously I don't think we're going to be doing that.
Yeah, we already finished that.
Also, do we swap it around?
No, we already finished that. Remember when we were at school and we did the research methods poster?
Oh, okay. So we did it.
That was
before.
outcome 3, yeah.
Yeah. All right, cool. That's it.
Yeah, so don't worry about area of study 3. We've already done area of study 3. That was the research methods project that we did. Yeah, so this is basically our last SAC, and after this, hopefully you guys can do some trial exams and get those done, because your exam is on 12th of November, so you've still got a little bit of time, not a lot of time, but yeah, you still got some time there. So if we can get this SAC out of the way tomorrow, we can get straight on to doing some exams. Okay. Alrighty, so what other questions do you guys have relating to the SAC content for tomorrow? Do you have any questions about the SAC or the structure of the SAC or anything like that? Okay. Okay, I'll go through the structure of the SAC. Now I have posted it on the school box, but I will go through it again. All right, so this is the structure. I don't know if you can see that. Let me see if I can make that zoomed in. Okay, so yeah, so we're talking about the structure of the SAC. So looking at, you know, it's just a normal structure that we usually have. So you've got 45 marks. That's the total number of marks that it's going to be marked out of. 20 multiple choice questions and 25 marks worth of short answer questions. No research methods except for the research methods that's already in chapter 11, which is the use of informed consent in mental health research and the use of placebo treatments in mental health research. So those are already in outcome 2. So those are not like specific, like separate research methods topics, if that makes sense. But other than that, you're not going to have other like research scenarios or things like that. Yeah, and tomorrow it's at 2:30 in our period 6 online lesson, 55 minutes. So hopefully we can finish up by about 3:20, 3:30, something like that. And very important, the SAC will be completed in the same structure as always on Education Perfect via Zoom. So if your camera on your laptop doesn't work or something, you have to organize to have your Zoom running on your phone. Or if your phone camera is stuffed, then you have to organize like your sibling's phone or your parents' phone. Okay, cameras have to be on. If cameras are not on, then obviously you can't do the assessment. So you have to organize yourself before the class. Usually I don't have this issue with you guys, so it shouldn't be a problem. But yeah, on a scale of 1 to 10, how hard is the SAC? I don't know, maybe, I don't think it's hard. I think it's easy. Maybe like a 7 or a 6. Yeah, I don't know. It's like, yeah, you shouldn't ask the teacher how hard the SAC is because, yeah, it's 6 or 7. It's not that hard, honestly. Okay, can you please explain the difference between behavioral and cognitive part of CBT? Yes, I sure can. So let me do that. Okay, so it's the same PowerPoint of chapter 13. So let me just reshare chapter 13. All right, and then go to behavioral and cognitive components, right? So that comes under our psychological evidence-based intervention as well. So CBT is a psychological evidence-based intervention because obviously it's focusing on our thoughts and our feelings and how we can address our thoughts and feelings with regards to specific phobia. So in terms of your specific question, which was differentiating between the cognitive and the behavioral component, just look at the names of the terms itself. So cognitive is relating to our cognitions, which are our thoughts and feelings. So in the cognitive component of CBT, we're trying to address the patient's way of thinking. Okay, and remember that people with specific phobia tend to think in very irrational and negative ways compared to the rest of the population. Okay, irrational meaning that they think a tiny spider is capable of eating them alive, compared to someone else who might not think in the same way. Irrational means unreasonable, okay, or out of reason, out of the bounds of reason. So in cognitive component of CBT, what we do is we sit with the patient who has specific phobia, we help them to identify the negative thought, which could be, for example, that touching a dog will kill them. So we identify that negative or unhelpful thought. We carefully examine each thought, okay? So the psychologist might ask the patient, okay, have a look at that thought, analyze that thought, okay? Touching a dog might kill you. Carefully look at it, carefully look at the wording that you use in that thought, okay? And then obviously the psychologist would encourage the patient to evaluate how realistic or helpful that thought is. So the psychologist might ask, what do you think about this thought? Don't you think it's a little bit, don't you think it's a little bit unrealistic? And they might try to, without judging and without making the patient feel ashamed or guilty or bad, they try to get the patient or steer the patient's way of thinking to maneuver them to kind of think in a more positive and productive way. So rather than thinking that the dog might kill them, eventually the psychologist would work with the patient to think that, the dog is friendly and patting the dog will allow me to become more familiar with him. So it's a more productive thought. So essentially the cognitive component of CBT, in a very, very, very few words, all it means is we're changing the negative and irrational way of thinking from being unhelpful to being more helpful and productive. So that's the cognitive component, which is all about the thoughts. The behavioral component is about changing the actual behaviors. So this often involves addressing those avoidance behaviors that we always talk about, okay? So obviously we need to get rid of the avoidance behaviors, and we need to kind of replace them with behaviors that are more helpful or productive. Okay, so remember the cognitive component, replacing negative and unhelpful thoughts with more productive thoughts. Behavioral component of CBT, replacing negative and avoidance behaviors with more productive and helpful behaviors. That's essentially what it is in a nutshell. Okay, so we get rid of the avoidance behaviors and we replace the avoidance behaviors with behaviors that are helpful. Behaviors like breathing retraining, muscle relaxation, meditation, exercise. All of these are things we've already learned about, which we know help to ease stress and anxiety symptoms for patients. Okay, so essentially that's what the behavioral component of CBT is. Replacing negative and avoidance behaviors relating to the specific phobia with more helpful and productive behaviors that will help to relax the patient and, help them to be in a better state of mind. So yeah, that's the main difference between the cognitive and behavioral components. Okay, so hopefully that makes sense. And yeah, just looking at the limitations of CBT, just know any one. Yeah, like most of them are pretty straightforward. We know avoidance behaviors are quite strongly established. So it's not just like, oh, yeah, we'll just do behavioral component of CBT and within 5 minutes, your avoidance behavior will be gone. That's not how it works. It's actually quite deeply entrenched within that person or the patient. So it's kind of hard to undo avoidance behaviors. And it's easier said than done, essentially. So that's one of the main limitations, that changing thoughts and behaviors are very easy to talk about and put on paper. But when it comes to actually working with a patient who's got a specific phobia, especially like, as I mentioned in previous lessons, like especially if the patient specific phobia is based off like a traumatic experience, it will take a long time. And some patients might not even be willing to really, to really continue for that long. Okay, so that's essentially the limitations of CBT. Okay, what other topics do you guys want me to go through? Have a look through your PowerPoint. So 11, 13 and 14. And let me know. Remember, it's not all of chapter 14, just up to the resilience topic that we went, just up to the social support topic that we went through. Okay, the social protective factors. Because the trans-theoretical model of behavior change is removed for this year. So just, yeah, you should know the adjusted study design topics. Okay, what other questions do we have? Or what other topics do you guys want me to clarify? Oops, okay, minimize that. Okay, it doesn't look like anyone is bringing up any new topics. All right, so what we might do in that case is I might just probably end the lesson here. If you have any other questions, obviously feel free to email me throughout today, that's fine. And yeah, just make sure you do study for the SAC. Don't miss out on any topics. Like I say, you can just study mainly using the PowerPoints. So that's not a problem. And yeah, just make sure that you also look through the practice SAC. If you need to rewatch the video on going through the answers to the practice SAC, you can do that. If you weren't present for the holiday class, also catch up on the videos that we covered in the holiday class, especially the one where we went through the answers for the practice SAC.